Thank you, Professor Deman, and thank you, the organizers, for inviting me here to share our experience in acute liver failure. I'm going to stress upon mainly what makes us select and deselect these very difficult group of patients, especially in our environment where deceased donor organs are not freely available, and you have to go through the tough task of convincing a live donor from the family to donate under these emergency circumstances. I didn't make this green design, but it's something coming here. Anyway, it's fine. So I believe that 5% of all transplants in the US are done for acute liver failure, and about 10% in Europe are done for acute liver failure. In our own series, about little over 6% have been done for acute liver failure. But if we include all the ones that had subacute hepatic failure and acute on chronic liver disease, that makes it about nearly 10%. So as we all know, I mean, I don't think I should go through the definitions, but the common etiology seen in India is hepatitis E. Hepatitis E, hepatitis A, drug-induced, which it could be tubercular, Ayurvedic medicines, organophosphorus, paracetamol, and we've actually done 2 cases where they received anabolic steroids. And hepatitis B, Wilson's disease in children, pregnancy-associated liver failure, and of course indeterminate, which makes up approximately half of these patients, half of the proportion of the patients needing transplant. In the US, the commonest cause by far would be acetaminophen and other drugs, then hepatitis B, hepatitis A. E is pretty much unknown, although has been reported recently. Since transplant is a very complicated undertaking, it means lifelong immunosuppression. There is an operative mortality of around maybe in this group of patients to the tune of 15 to 25% patients. There is, if you do a live donor transplant, risk to the living donor. There is use of scarce resources. Therefore, the patient should be transplanted only when spontaneous survival is unlikely. And you should catch them when at this point, when spontaneous recovery is not possible and they have yet not sustained permanent neurological damage or have gone into multi-organ failure or sepsis. So that point is the one that you have to catch. King's College criteria have still, I believe, they have stood the test of time, and we use them, and we've actually validated King's College criteria in our own group of patients, as I shall show you later, and we still go by them. We looked at about 31 patients in about the 18-month period from July of 2010. And we looked at patients who actually did not go for transplant and who met with hepatic encephalopathy, 2 out of the 5 criteria. And their positive and negative predictive value was pretty low. So I think on their own, bilirubin, INR do not predict death from acute liver failure, as well as the original 3 out of 5 do. People who've looked at MELD, especially in the US, feel that their predictive value is a little better. They predict survival and death respectively after transplant and without transplant better than King's College criteria. But then the problem with this paper that was published from Mayo Clinic is that 20% of their patients had primary non-function, which is not a group that King's College originally looked at in the 800 to 600 odd patients. So different people use different selection criteria. We use King's College criteria. The previous speakers already talked about patients who should be deselected, but from our point of view, we would not do someone who's got uncontrolled sepsis or advanced multi-organ failure or has sustained brain damage. We do not do ICP monitoring, but if we were to do it, then cerebral perfusion pressure is what you look at. We would pretty much transplant anyone who has bilateral equal and reacting pupils, sometimes even unequal. But as long as the pupils are reacting, we would assume recoverable cerebral function or dysfunction and do the transplant. Decerebration is not a contraindication. Brain edema on CT is, of course, again, not a contraindication. Of advanced cardiopulmonary disease, which is just like a comorbidity, is a contraindication. We don't always do a CT scan, but when there is recent and sudden deterioration in the neurological status, we sometimes do a CT scan of the head. And the usual measures used to preserve these patients cerebrally, basically, have been discussed in the previous talk, so I won't stress on that again. Now, what happened to the 53 odd patients that were satisfying King's College criteria in our series from July of 2010 over an 18-month period? We transplanted approximately half of them, and 24 out of these 28, which is about 88%, did well. And the reasons for not proceeding for transplant were lack of suitable donor in about half of these cases, sepsis in 6, renal failure in 5. 2 of them got better, so 10% got better, and 3 were brain dead at the time that it came to transplant, and 2 had intracerebral bleed. So these are the reasons for not proceeding. And of course, only 2 of them eventually lived. 23 out of the 25 died. Out of a total of 1,223 transplants that we've done as a team, 32 have been deceased donor transplants and the rest live donor transplants. 118 emergency transplants have been done for acute liver failure, subacute failure, as well as acute and chronic. 79 of these have been acute liver failure, and 78 of them have had living donor transplants, and 1 had a deceased donor transplant. 50 have been adults and 29 pediatric patients. Looking at the etiology of the ones who have been followed up for at least 1 year, 68 patients. Commonest was indeterminate, and the next was hepatitis E, and then was antitubercular drug-induced, and then the others. Graft type, these patients mainly had right lobe grafts with MHV or occasionally modified grafts, or left lateral, that's in kids, or left lobe grafts. No ABO-incompatible transplants were performed. Mean MELD score was 35, 41 out of 43 adults, and 60% of the children required preoperative mechanical ventilation. Median time to listing, from listing to transplant, was 41 hours, ranged from 8 to 168 hours. Median day of transplant was day 2 after admission. No patient needed pre or intraoperative CRRT, but postoperatively 3 of them needed CRRT. They were transplanted with grafts which were an average of about 1.15 GRWR. Their mean postoperative ICU stay was 9 days, hospital stay 22 days. And compared to our entire LDLT series, of which has 91% 1 year and 86% 5-year survival, emergency liver transplants had 89% 1 year and 82% 5-year survival. This shows pretty much the same thing. This is the survival function for the acute liver failure patients, approximately 90% 1 year and about little over 80% 5-year survival. So we've transplanted our patients at an average of 41 hours. If you look at the other series, generally it varies between 60 and 120 hours, and these are all varying. These are all LDLT series, basically live donor liver transplant series, because the cadaveric transplants tend to happen much later. And the survival figures are variously between 67 and 89%. Generally, what I wanted to show you here was that the sooner you transplant them, probably the more percentage of patients you will save, although there is an argument saying that you will probably do some unnecessary transplants. Now, we believe that not much progress has been made in refining criteria which will tell us better what kind of patients are likely to survive and what are not. So we looked at SIRS in our group of patients. We took 28 patients that were transplanted for acute liver failure during the 18-month period from July 2010, and of course they have 1 year follow-up. And we separated them into 2 groups: patients who had systemic inflammatory response syndrome prior to transplant and those who did not. And of course, SIRS was defined as standard sepsis and multi-organ failure consensus conference definition: temperature, heart rate, tachypnea, PCO2, TLC. And the presence of 2 or more components was defined as SIRS. And we, out of In that period, we did 366 transplants. Out of them, 28 acute liver failures, 12 had SIRS, and 16 did not. Their etiology, MELD score, age of recipient or donor, and GRWR was no different between the two groups. Preoperatively, the only things that were significantly different between the SIRS and the no SIRS group were heart rate, which is expected, temperature, again, which is expected. Respiratory rate was not statistically significant, but it was obviously different. And PCO2 was higher in the SIRS group patients. Of course, by definition, this would be the case. TLC was again higher, but didn't turn out to be statistically significant. Bilirubin, INR, transaminases, etc., they were no different between the two groups. The other factors I already told you that the groups were no different. Intraoperatively, cold and warm ischemia times were similar, around 60 and 40 something minutes. IVC clamping time was similar, and hepatic time was very similar. Postoperatively, ICU stay was higher in the ones who had SIRS pre-op, and extubation was prolonged in them, and these were the only factors that were different. The LFTs and at day 3 and day 7 were no different. And we found that according to the Claviant-Indo classification of surgical complications, grade 3 to 5 complications were very much more often seen in the SIRS group, the green ones, compared to the non-SIRS group. So this was statistically significant. So they had more morbidity after transplant. And 9 out of the 12 SIRS and 15 out of the 16 no SIRS groups survived. And of course, the survival at 75% and about 93% was statistically different between the two groups. Now, looking at DDLT versus LDLT data, we don't have that for ourselves because we only done one transplant, one deceased donor transplant for acute liver failure. But generally, the survival figures are better with living donor liver transplant, which I would assume to mean that these patients are more often able to get grafts and probably earlier in their course of acute liver failure than the deceased donor patients. This is from the SRTR data. Within a week, only about 57%, and within 15 days, only 59% of the listed patients are transplanted with deceased donor organs. So I'm ready for my conclusions now, which is to say that HEV and Wilson's and cryptogenic are the important, well, cryptogenic can't be a cause, but they're the so-called labeled etiology of acute liver failure in India. Approximately 25% of serious referrals for liver transplant will eventually materialize in living donor liver transplant. King's College criteria still work for Indian patients. Patients with SIRS preoperatively have a worse prognosis after liver transplant. And SIRS can therefore refine King's College criteria to predict survival and may help to hasten the process of liver transplant those who have SIRS. So it's an indicator that if somebody's got SIRS and you're preparing them for transplants, you better rush it. And 50%, approximately 50% patients in DDLT setups never reach transplantation, or 40%. Logistics of LDLT for FHF are obviously formidable, but results of living donor liver transplant in acute liver failure are pretty good, and I believe it's because of good graft quality and short listing to transplant interval. Thank you very much.
For an excellent talk. Just a question actually. Now, do you also do the IC monitoring for the transplantation?
No, we don't. We don't do ICP monitoring.
Why do you don't do it actually? What do you feel about it?
I think that ICP monitoring is probably more called for in setups where they have more hyperacute failure, they have more cerebral edema. So if you do it in populations that have paracetamol overdose or drug poisoning, who again have more cerebral edema, there the changes of ICP could be sudden, and while the patient is waiting for deceased donor organs, it also takes longer. So I think that's the justification I gave to myself over all these years. But honestly, when I first came from the UK and I used to, we used to manage patients with ICP monitoring, we didn't, both the neurosurgeons and us, we couldn't gather enough confidence to actually put the bolts in the first place. But then we've managed nearly 70 patients without it, and we seem to be doing okay.
You are comfortable?
Yeah.
Okay. May I have the question and comment? Yeah, Dr. Subhash, please.
I think one of the, once you get onset of cerebral edema, I think the prognosis is very bad. So in a doing a liver transplant setup, you're probably, instead of trying to put a bolt in, probably better off trying to do the transplant early. So that's one of the main reasons why, we haven't chosen to do intracranial monitoring. But obviously in situations where there is a great potential of spontaneous recovery, obviously there's a role. My question is on systemic inflammatory response syndrome. I thought acute liver failure was in many ways systemic inflammatory response syndrome with, vasodilatation, low SVR, high TLC, necrotic liver. So are you mixing up groups there and trying to see whether, the heterogeneous group of patients with acute liver failure that you separate into two separate groups? Because as far as my understanding of acute liver failure is that it mimics systemic inflammatory response syndrome very closely.
I would agree that if in a given patient of acute liver failure you were to wait long enough, you would probably end up with SIRs in most of them. And but what we did look at was, we tried to basically separate groups that did badly compared to those who did well. I mean, patients who did well. And we did strike upon this as per the strict definition of SIRS. I think it just goes on to say that people who are sicker will do worse, I mean, in simple terms, which we all realize. But the separation of the groups was done strictly on definition.
So you took the 3 criteria positivity for the SIRS, no?
Yeah, that's right.
Yes, Dr. Mohammed.
Just to complete that comment on SIRS, I think you're right in saying acute liver failure is SIRS, but not all patients will have SIRS.
Yeah.
The reason for that is the hyperacutes, where we used to describe what is called a toxic liver syndrome, particularly paracetamol, perhaps the hepatitis A, the hepatitis E, where 90%, 99% of the hepatocyte masses necrosed, you will get SIRS because it's a necrotic organ like in any other organ. Whereas the subacutes, what you call as seronegatives, the cryptogenic, they have a very slow and indolent course. They go on for a month, 2 months, and they purely die of liver failure and a very cholestatic picture. And when they die really of sepsis. So when they deteriorate, it's not SIRS. When they deteriorate, if you transplant them, they do worse than the hyperacute, which is not an infected patient, but it is SIRS. So I'm not very sure about your conclusions. But the other point I want to make is you've had very small proportion of patients on dialysis preoperatively and very small in the postoperative period. And that tells something about the population of patients you have, and a significant proportion of them probably are not the SIRS patients because these would require renal support, which is why the numbers that you have is so small. It's very difficult for you to come to conclusions like that. Because historically, if you look at the data, in my talk, I would talk a lot about the pathology of acute liver failure. It's important to understand. The hyperacutes or the paracetamols and the drug-induced, which have the SIRS, even though have a very rocky postoperative period, don't necessarily do worse than the subacute. Actually, the subacutes who have a very stable course, a significant proportion not even ventilated, do not do as well as the hyperacutes. So it's
this population does not consist of, the analyzed population does not consist of any subacute hepatic failures. They're all fulminant hepatic failures. If you saw in the beginning slides.
I know you're mixing up, you're mixing up terminology now. I think acute liver failure encompasses all of these.
No, I understand that. But the thing is, we've taken patients who had typical definition of less than 4 weeks of onset of coagulopathy, encephalopathy, and hyperbilirubinemia. So we've actually excluded from this particular analysis of 68 patients, they were purely fulminant hepatic failure. The subacutes and the acute on chronics have been the other 40-odd patients, which make up the 118.
Okay, thank you.
Do you mean to say that liver transplant results are better in patients with the hyperacute liver failure than in those with the subacute liver failure?
Yes, if you look at all of the registry data, you will find that the subacutes don't necessarily do better than the hyperacutes. The hyperacutes are very sick. Some of them may not come to transplantation, But the problem with the subacutes is they've had such an indolent course, septic complications are very high in them. And number two, a significant proportion of them will also have bone marrow suppression in the post-operative period. So it's easy for people to think subacutes are very stable, they'll do better, but actually they don't. If you look at all registry data, the subacutes don't do better.
I think the problem with that assumption for a living donor liver transplant population patients is that in the deceased donor system, you're basically obliged to wait for the organ, and you cannot, in the real sense, select your patients correctly or prepare them properly necessarily. So I think that we are, although it's tough on the donor to have to donate suddenly, but in some ways patients are at an advantage if they're offered a living donor liver transplant, because they're better prepared patients and let's say clinically better patients than the ones for DDLT. And most of the registry data is obviously based on DDLT data.
Yeah, that's true. Yeah. But I'm talking about the Western statistics. If you look at UK statistics, if you super urgently list a patient, they will get an organ quicker than you can work up a diseased donor, because super urgent category will give them first priority for organ. And if there are 800 liver donations in UK, there are only 365 days. So they are likely to, it's exceptional to have a patient wait for more than 72 hours for an organ. And this argument between hyperacute and subacute not doing well, actually the hyperacutes are the ones who desperately need the organ immediately. The subacutes can have an organ 3 or 4 days later. In spite of that, they don't do better than the hyperacute. That's the point I want to make. It's not about how quickly you transplant them. It's not about cadaver versus living donor. In our country, if you put them on a cadaver list, majority of them would be dead. You cannot equate that to the West because the system is very different. The other question I wanted to ask you is, how many of your patients you worked up and then you didn't transplant them and died? Do you have an idea of
Yeah, I do. I think it's in that group which didn't get transplanted. So just let me open this for you again.
Because that tells you something. So living donor liver transplantation is not an answer for everybody if some of your patients are going to die while being worked up.
So this is the group. Okay. So donor was not available, obviously doesn't pertain to what you're asking. But people who had sepsis, people who had renal failure, and the guys who got better, of course, and the ones who became brain dead or had cerebral bleed. So I would say about 30% of the ones who were prepared couldn't be